We are going to go into the third plenary of the day. Fairly important topic, and the title makes it self-explanatory why. We're going to be discussing global pandemic preparedness. I don't think I need to add too much more to explain what that's about and why it matters. The last 2.5 years have, let's just say, taught us a few lessons about healthcare systems, and the need to be able to respond effectively, equitably, and rapidly to global pandemics. We have a few moving parts to this session. We're going to start, and we're very, very privileged to have a video message from Dr. Tedros Adhanom Ghebreyesus. He's not here, so he can't accost me for butchering his name. He's, of course, the Director General of the World Health Organization, and most of you will know him simply as Dr. Tedros. We have a couple of minutes, it's a couple of minutes long. If we can get the video up, and then after that we will get into the actual discussion.
Your Excellency, Lord Marland, Excellencies, dear colleagues and friends, the COVID-19 pandemic demonstrated the potential of public-private collaboration for health. The partnership between governments and vaccine developers helped to deliver life-saving vaccines in record time. Despite the groundbreaking scientific advances, the world remains unprepared for the next pandemic. At the request of our member states, WHO has made 10 proposals for an enhanced global health architecture with stronger governance, stronger financing, stronger systems and tools, and a stronger WHO at its center. We're committed to working in partnership with governments, the private sector, the scientific community, and civil society to build this architecture. Representing 56 countries and more than 2.5 billion people, the Commonwealth is a unique ally in this endeavor. Earlier this year, Secretary General Patricia Scotland and I signed a memorandum of understanding to expand our collaboration. I was delighted to be at the Commonwealth Heads of Government meeting in Rwanda in June, where a new set of ambitious commitments on health were made to build climate-resilient and sustainable health systems. Engaging the private sector will be vital to achieving these commitments. Thank you all for your leadership and commitment to working for a healthier Commonwealth and a healthier world.
Great. It's a good way to set the scene. I'm now going to go into a one-on-one conversation with Sir Patrick Vallance, who is the UK government's Chief Scientific Advisor. Sir Patrick, please join me on stage. Just use these two. And we're going to spend around 20 minutes having a bit of a conversation about the issue of pandemic preparedness. To start with, Sir Patrick, thank you, first of all, for being with us. Any takeaways from Dr. Tedros is very, very brief, but I think quite loaded with information and quite important information. Any reactions or takeaways to his words just now?
Yeah, maybe three things to take from that. The first is, as he rightly says, there will be another pandemic. So it's not a matter of if, it's a matter of when. There will at some point be another pandemic. So we must be absolutely prepared for that. The second is that industry is a really important part of the solution, and we need to work out how we can involve industry in the right way to get to the answers that we need to get to. And the third is that this is, by definition, a global issue. So it's a matter of making sure that we have the cooperation and collaborative systems in place to get this right, with equitable distribution of whatever's required to tackle the pandemic. So I think there's a lot to do, and he's right to flag it as one of the key things that WHO should focus on.
One thing that kind of stood out for me and you said it early on, is the world remains unprepared for the next pandemic, which is a bit sobering given the experience of the last 2.5 years. Is that an assessment that you would share?
Well, I think I suspect the world is better prepared than it was before, but is it fully prepared? No. And are memories short? Yes. And so there will be some sort of movement away from some of the things that have already been thought of as being important, dismantling of some of the infrastructures that have been so crucial. So it's incredibly important that we do not, at this moment, take a step back. We need to build the pandemic preparedness that's required. And in my view, one of the things that's important is not to think that you create an infrastructure or a response which sits there waiting for a pandemic, because that won't last. It needs to be an infrastructure that's about strengthening healthcare systems around the world and response mechanisms that are relevant to everyday healthcare that can be easily scaled. And I think that is the challenge.
Which is where the word preparedness comes in.
Yes.
Speaking of being in a better position than the world was in 2020, could you give us your thoughts on what worked and what were some of the common features of the response that we saw from the healthcare sector, from the scientific community globally, that in the end did manage to get a meaningful response out there? And to the point that you've just made, what do we need to make sure we don't backtrack on?
Well, I think that whichever way we look at it, the ability to get a vaccine produced within essentially a year of a new organism being identified is remarkable. I don't think anybody would have predicted that that was going to be possible beforehand. And that's a huge scientific success story, which was made possible because of some of the technologies that have been developed, whether that was vector viruses or messenger RNA vaccines, in order to be able to make those things so quickly. So that's a remarkable success story. But I think if you look at it, there are lots of things that could have been done quicker. And that's really behind the proposal for a 100-day mission. So if you ask the question, what would have happened, just paint a scenario, what would have happened if within 100 days of a new viral pandemic threat being identified, you could have diagnostics that were approved and reliable, you could have vaccines that were ready to be produced at scale, and you could have an initial regimen of therapeutics. That means that in, let's say, May 2020, if you could have had all of that ready, how that would have changed the response to this across the world is dramatic. We would have had hundreds of thousands, possibly millions of people in much better condition, and it would have been a totally different need for some of the other interventions, the non-pharmaceutical interventions that took place that had such a devastating effect as well. So I think that's really where we've got to go. What worked well this time? I think scientific collaboration across nations was superb. I mean, there was huge open collaboration, regular contact, regular discussions, and very clear ways of working. I think the same was true in sharing of clinical information, sharing of data. Could have been, quicker, but it was actually open and people really wanted to do it. I think those are things we mustn't lose. And I think interdisciplinary research, so the bringing together of virology, behavioral science, engineering, chemistry, those things worked really well, I think.
You mentioned the 100 Days mission, which is something that you led the development of and the launch of, and as you've already articulated, it's basically the aim is to make sure that next time a pandemic comes, within the first 100 days, we can get it right, in short. Where are you in that process? Where are we in that process of hitting that target? What are some of the key components that need to come together? One of the standout issues is public and private, and how those two work together. Could you give us a bit of an insight into where we are, what's it going to take to get there?
Yeah, so it emerged from G7, but of course isn't a G7 thing, it's a global thing, and WHO are heavily supportive of this, and G20 and other groups. So this is something that needs to be for everybody. There are three sort of basic principles that we laid out. One was restock the armamentarium. In other words, make sure that we've got the building blocks for vaccines, therapeutics, and diagnostics. The second was make the exceptional routine, so build all of that into everyday healthcare, and make sure that things like clinical trials are being run in healthcare systems around the world during peacetime, as it were, so that they can be activated during a pandemic. And the third is, and this is really an important one as well, establish the rules of the road now. So you don't spend 8 months at the beginning of a pandemic trying to negotiate things like transfer of samples or funding of vaccines in countries around the world, that you get those sorted out in advance. So those are the three principles. There are a number of recommendations. I would say there's good progress in some, very good engagement from industry, and industry actually believes that the 100-day mission is totally possible. Some areas are not progressing as fast, and we need to keep an eye on that. We've now formed an international secretariat to monitor progress against the different objectives. And this is a long-term plan. It's not going to be possible to get to 100 days for every possible threat in any time soon, but it will be possible for some of them. And a foundational requirement is a global surveillance system, pick things up early, and it's going to be important to make sure that as we do that, that we have international collaboration, distributed manufacturing hubs and things which are sort of coming together with, as I say, a very strong belief from industry that this is achievable. What it does need, though, is for WHO and others to come out with a priority pathogen list so that we know where to start. We need sort of the top 20 risks agreed so that the different components of the 100-day mission can know what they're working against.
And forgive the layman's question, but what's the complexity behind getting that list? Why is that a stumbling block?
Well, it's pretty close, and WHO and CEPI are working together to try and get this list together. Frankly, most of it now is just details of exactly what goes on there, and I think this is a totally solvable problem that should be sorted out very soon.
Gotcha. You mentioned this is something that came out of the G7, but it's not about the G7, and again, it's kind of self-explanatory. A global pandemic is a global problem. Where does the Commonwealth fit into that in terms of being able to proactively contribute to making sure that pandemic preparedness isn't something that remains a theoretical thing?
Yeah, well, I think Commonwealth countries were involved in all sorts of different aspects of science, technology, manufacturing, response to the pandemic in all sorts of ways across the world this time. And there is a great strength across the Commonwealth, both in terms of scientific expertise, and I'll call out one that was quite remarkable actually, which was the work that was done in South Africa on genotyping the virus, which, paradoxically led to a reaction against them, which was really, really problematic. And we've got to solve that.
I think it was twice.
That's crazy, because if you're giving the information to the world to help the world, there shouldn't be an ab reaction to that. But there's great science going on. There's obviously a huge need across the Commonwealth in term as well. And I think there's a massive opportunity for things like regional manufacturing, which will be good for the bioeconomy in countries as well, and indeed for healthcare strengthening, healthcare system strengthening. And I've mentioned this a couple of times. If you're not running clinical trials in your healthcare systems, then you can't scale that when you need to for a pandemic. And running clinical trials in healthcare systems improves healthcare. Yeah. So it ought to be part of everyday practice. So I think there's a big Commonwealth opportunity here, actually, and a great opportunity to think about how the Commonwealth can come together to contribute this. And then a rather specific one is we're looking for a science and technology expert group to be part of the 100-day mission. And I think thinking about whether there are individuals in your country who might take a global perspective and be part of that group as we seek nominations would be very helpful.
I believe that's one for everyone in the room to have a think about. Now, in the end, there was a global response to the pandemic. We did get vaccines. But as we all know, the response was also characterized by some deep inequities. And we had all the issues around vaccines being either not being deployed or being deployed late. How do we tackle that for the next pandemic? What's the role of science and innovation and technology in hopefully getting rid of some of this inequity?
Well, so there's one bit of this which is around the rules of the road question. You know, what is it as a world we want to do for the next pandemic? I'm going to take an assumption, which is what the world would like is a much more equitable distribution, because the whole point about a pandemic is it's everywhere, and if you don't treat it everywhere, it doesn't go away. So I think setting those mechanisms, many of which are financial, not all of them, but some of them are financial mechanisms, in advance of the next pandemic, to say, how would you trigger demand signals for vaccines or therapeutics or diagnostics, and how would that be funded in advance, I think is something that can be done now. The second thing that can be done now is thinking about regional manufacturing, so we don't end up with a situation where we have either a bottleneck of manufacturing or a limited distribution possibility. And I think there's a big opportunity right the way around the world to think about how to make that happen, provided it's used all the time. You don't want manufacturing facilities that lie idle because they cannot be activated.
Yeah, as you were speaking, I was thinking about the example, I believe it was in South Africa, where a COVID vaccine plant was set up, but then there were reports that there've been no orders, so we might have to shut it down or repurpose it.
Yeah, I mean, manufacturing requires being used all the time. The other area that's interesting in terms of equitable distribution is thinking about things like what is the ability to operationalize this in different countries. And things like needle-based systems that require cold chain storage and complicated mechanisms to get it there are not easy to get out across the world. So developing technologies that allow much easier storage, distribution, and needle-free delivery systems, I think is going to be an important part of this as well.
Is it fair to say that technology is going to play a role in this? We're going to have a more in-depth discussion around health tech and health delivery. Technology and innovation seems to me, as a layman, that has to be part of the solution of how you make this more equitable. Is that a fair comment?
Yes, I think technology is definitely part of the solution for any future pandemic, because if you don't have pharmaceutical interventions, by which I mean largely vaccines and therapeutics, then you are completely reliant on non-pharmaceutical interventions, which means things like isolation, quarantine, separation of people, things that we know have a big effect on economies and have a big effect on healthcare systems. So it's really important that we get as quickly as possible to the technologies that are required, and that needs to be done in a way that doesn't increase inequality. So they cannot be technologies that can only be available to a few wealthy countries. They need to be technologies which can be used globally and can be accessed easily.
Slightly different angle on this, slightly different question. But one of the issues that came out through the pandemic is the importance of trust between the authorities and citizens. Both, from the very beginning of the pandemic, trusting in the information that's being disseminated, trusting in the safety of vaccines. We've all seen the anti-vax movements in certain parts of the world. What are some of the lessons learned there, and how to hopefully, next time around, make sure that trust isn't lost or in some way undermined?
I think it's obviously a critical question, and one that is, as you say, very, very relevant with anti-vax movements and others across the world. And I was thinking quite hard about what the components of a trustworthy system look like. And I came up with the acronym TRUTH, where T stands for transparency, first of all. So making the information available as quickly as possible to everybody. So don't keep it hidden, get it out there. The second is making sure that the information is reliable, by which I mean methodologically sound, involving the right scientific disciplines, and can be explained to people so they believe it's reliable. The third is uncertainty. Science is often perceived as an absolute black or white, whereas it's not. It is an understanding of today which will be overturned when more experimentation is done that shows you're not quite right. So expressing the information in terms of uncertainty, what you don't know as well as what you do know, is important. And there's a tendency sometimes not to do that, whereas actually the public are smart and they can see that, and that helps. So I think expressing uncertainty. The fourth is timeliness. If you give information at the wrong time, too late, you will lose trust. You know, if you knew it today and you chose not to give it today, then people will ask why. And so the timeliness is important. And the final part of the truth acronym is humility, which is you will be wrong. We will be wrong sometimes. And so it's very important in building trust in the population to admit when you got something wrong and explain now what you think is right. And whereas that is a fundamental tenet of science, which is you think you know something, you try and do an experiment to improve knowledge, you find out that what you knew before wasn't right at all. Scientists like that. You think, oh, that's really interesting. I didn't know that. Now I know something different. Politicians view that as a U-turn. And so there's a sort of quite interesting sort of linguistic and narrative problem that needs to be overcome. And I think that's a key part of building trust as well.
I like the acronym. That works very well. Final question. I know you have to run soon. We've spoken about the 100 Days mission. You've mentioned how important buy-in from industry is in that respect. Beyond the 100 Days mission, where do you see the opportunities for the public and private sector to really come together here to make sure that, as you put it, you kind of, how can I? What's the analogy? We spoke earlier. Used the analogy of the military, right?
Yeah.
You don't wait for war to start before you start producing the equipment, and that in some ways is what happened with the pandemic. Are there other opportunities where you would like to see more public-private partnerships?
Well, I think there's a public-private partnership thing in surveillance. You know, how do we pick up early warning signals that there's something going on? That's a classical sort of sampling method, but it's also things like data sources from search engines and other things that give you a signal that something's happening. So I think there's a big opportunity for much more advanced surveillance mechanisms across the world, which could be a public-private partnership. Definitely opportunities in therapeutics, vaccines and diagnostics. That's got to be public-private partnership in my view. And in fact, what's interesting is the industry is probably the most bullish about, yes, they can do the 100 days. Yeah. So let's back that and support them to try and get it at the right price. And then I think there's obviously public-private partnerships around the distribution and implementation side of this as well.
The one word there that stands out for me is surveillance. I know it's not meant in a sinister way, but
yeah.
that might feed the anti-vax movement. They're surveilling us. Perhaps just call it monitoring. Anyway, Sir Patrick, thank you so much. We're going to unpack some of this a bit more. Unfortunately, Sir Patrick has to leave us, but thank you so much for your insight, your perspectives, and what can I say other than keep up the good work on the 100 Days mission. Sounds like it's exactly what's needed to make sure that Dr. Tedros doesn't have to repeat the words of "we are not prepared for the next pandemic." Please join me in thanking Sir Patrick Vallance.
Thanks very much. Thank you.
We are going to move into stage 3 of this session. And at this point, I would like to invite Fergus Drake, the Chief Executive of Crown Agents, and Dr. Andrew Rickman, who is the CEO of Rockley Photonics, to join me on stage. And we are basically going to continue the conversation around pandemic preparedness. Gentlemen, thanks so much for joining me up here. A minute or two, each of you, give us a little bit of background, bit of context, how you're coming at this question of pandemic preparedness and what you focus on work-wise. Fergus?
Wonderful. So Crown Agents is a not-for-profit international development company working in 101 countries, reaching 108 million people a year through our health, humanitarian, supply chain and procurement work. But very much with regard to COVID-19, we were involved in the kind of nitty-gritty, the implementation. So it's wonderful to share a stage with Dr. Tedros and Sir Patrick Vallance at the 30,000 feet. We were very much into the specifics of how do you get the vaccine out into places across Africa, into the Falkland Islands, into those environments. So bringing that kind of grassroots perspective.
Right, great, thank you. And Andrew?
Thank you, thanks. Rockley is all about the monitoring of health and the prediction of how your health is going to evolve. And we weren't ready with our technology, unfortunately, for the COVID pandemic, but we're just about ready now. And this technology is taking what you see in your wearables today, those devices that measure your steps and your heart rate, and putting a technology that's about 1 million times more powerful in a wearable to allow one to be able to early diagnose diseases, track diseases, figure out the prognosis, where patients are going to go. And of course, that has a huge implication in the future in terms of any future pandemic, in terms of understanding what's going on in a region, being able to see where a heat map of people with particular conditions, and then being able to get to the population and treat the population effectively and quickly.
And you've got some of the devices with you,
Yep.
right? So it's not theoretical. They're very real. And my understanding is there's a lot of computational power in those.
Yes, so these devices, as I say, if you look at the wearables you have today, you may see a little green LED in the back of your Fitbit or your Apple Watch, or a red LED. So this LED technology is good at looking at particularly things like your heart rate variability, and blood oxygen, but not much else. And so what we've developed here is a photonics chip technology. It was developed here in the UK, manufactured at Newport Wafer Fab in South Wales. And this chip technology basically allows us to integrate a $100,000 benchtop spectrometry diagnostic instrument into a chip and put that on your wrist. And because it's chip technology, it can scale. Ultimately, it can be extremely inexpensive and be deployed across a great number of people. So we're peering into the interstitial fluids in your dermis and analyzing this interstitial fluids for things like glucose, lactate, alcohol if you've had a drink. We're also able to predict your core body temperature from your wrist spectroscopically, your hydration level, and also probe into your blood vessels to measure a whole range of cardiovascular characteristics, including blood pressure, continually with a wearable, non-invasively. So the implications for this in terms of a pandemic are that you have the tools that you can deploy on individuals to be able to diagnose diseases early. So that handful of biomarkers that I mentioned have been proven in, for example, in COVID, to be able to provide early diagnosis before symptoms, and to be able to give a steer in terms of the prognosis. Is this patient going to become seriously ill in the next few days, or is this patient likely to have an easier ride?
Fascinating. And it's not too difficult to see how that could make a huge difference when confronted with the next pandemic. Fergus, I suspect you would have liked to have some of those devices around during COVID. There seems to be some fairly obvious synergy between the work Andrew's doing and the work that you're doing. But give us a bit of a sense of some of the lessons learned from being on the ground and going that last mile, so to speak, right, of getting healthcare to where it's needed during a pandemic.
Exactly. So, I mean, just in terms of some of the work we were involved in, it was very much in the early days responding to the needs of the overseas territories to get personal protective equipment and vaccines into places like the Falkland Islands, where we had to use C-130 RAF jets. We needed to use a longboat to get it into Pitcairn. We also got it to the British Antarctic Survey. And these were people who hadn't seen light for 6 months. So they liked the vaccines, but they particularly liked the fresh fruit that we brought with them because they've been living off baked beans and Weetabix for that time. But through that and our experience of procuring for Ukraine as well and working with Gavi and UNICEF, it's all about better coordination in the supply chain. So how can we have inspections, freight forwarding work and procurement all speaking to each other? Because Sir Patrick was talking about needles. Actually, after about 1.5 years of the COVID response, vaccines weren't the problem. Syringes were the problem. The world ran out of syringes, and we also had all of the freight containers all around the world in the wrong places, so we actually couldn't get it to countries quickly enough on time. So that's the first one in terms of coordination about preparedness, stock forecasting and distribution. The second is information. Absolutely agree with the point that if we don't know where the disease is at any time, then we can't respond. That's why these things are incredible. We run something called the Health Pooled Fund in South Sudan, 800 primary healthcare units, getting 3,000 metric tons of drugs there. If we could have 1 or 2 of those in every one of those primary healthcare units, that could be a way to monitor, not surveil, but monitor the population and understand if there is a kind of an outbreak coming. So that's really important. And then the third point, again, Sir Patrick talked about, is having one central point of knowledge and information that everyone trusts. So when you're going through turbulence, everyone likes a chatty pilot. And having that information coming through regularly so that we know where we are as the world and we know how to respond quickly is absolutely vital. So those are 3 of our learnings.
Coming back to the issue of equity, because early on in the pandemic, there was certainly some nice rhetoric around we're in it together, we got to work together, et cetera, et cetera. In the end, we kind of know the story. It didn't quite pan out that way. You saw a lot of countries becoming quite selfish quite quickly when push came to shove, and there was an obvious divide between, I guess, what you could call the global north and the global south. Obvious lessons to be learned there. How do you see us avoiding a repeat of that kind of scenario, which, let's be honest, doesn't really help anyone?
Yes, well, I think obviously I would back 100% the 100-day plan that Sir Patrick has been pushing for the last kind of year or so. So to have funds standing by, ready to go for the surge, to know the rules of the road, you're always going to have national interest and the voters of your country wanting you to respond in that area. But we do need to have those structures standing by. So I'm very pleased with the support that's gone back to the World Health Organization now. That's the forum that we all buy into, and that's absolutely vital. But the other point Sir Patrick made is don't have duplicative systems. Let's focus on community health workers, strengthening health systems that can then be kind of ratcheted up as and when you need to respond very, very quickly. Because if they're duplicative, if they're standing by, they will not get funded. And actually using the structures we have is vital.
Thank you. Andrew, what's it going to take to get one of those devices around each of our wrists in here?
Well, I think
and how much is it going to cost?
Somewhere like, the funded health system like the NHS or, where people are paying significant amount of money for their health, then, it's realistic to imagine that everybody can have one. I mean, if you go into a hospital and have a procedure, you're being tested with a lot of different instruments for things that this can do. And so you're going to make it much more efficient for people within a hospital to be monitored with this technology rather than the labor-intensive processes that we have now. And then you've got the prospect of those individuals being sent home with the devices and continually being monitored. And that means getting people out of hospital beds earlier in a safer way. So that all looks very rosy, but then it still costs money. Maybe that isn't affordable for everybody in the world, not day one. But we actually designed these devices so they could be, you think about your wearable and that it's yours. But we designed these devices really like a mini instrument. So you can use a strap that's disposable. This one isn't, by the way. You can strap it and use it in different locations on the body. So this becomes actually, if you're imagining supplying it to a remote community, which couldn't afford to have everybody having one, doesn't have a doctor there, this becomes a easy to use diagnostic tool that you can use across the population, put it on the wrist, but you can actually use it over the body as well to diagnose a whole series of other conditions. So I think there's a very affordable way of deploying this technology, even if you can't afford to put it on everybody and have one on everybody.
And that is, of course, quite significant in the context of parts of the world where you may not have the infrastructure, you may not have the facilities that you have in a country like this or parts of Western Europe, but the need to have the ability to track and monitor and diagnose is no less important, right? And that was very much, I imagine that would have been very much the case during COVID. It sounds to me like the flexibility is there to at least have something, right?
Exactly. I mean, the practical issues are obviously that you do have internet coverage and that you have power to be able to charge up the devices, but they're not beyond on the capability in most situations. But then you have to have even if you're only deploying one or two into communities, you still need a funding model. Then you've got a kind of regulatory environment, which will be different in different countries. And then you've got issues associated with, what happens to that data. So really what you want to do with that data is it goes into the cloud, and you have a set of tools in the cloud that are basically constantly looking at that data. If you like an AI doctor in the cloud, a physician can still access the data, but you're getting so much data, you've got to process that data. So there are regulatory issues. Some countries will not want data to leave their borders, and that may be a problem when they don't have the infrastructure to support the AI doctor in the cloud. So the deployment still needs funding, support, and the right regulatory environment, and it's a different challenge in different locations.
Yes.
I was just going to say, this is a great example of let's spend money now to save ourselves money in the future, because everything is interrelated. Your comments there about you need to be joined up to the internet, you also need to have power. Well, there are huge opportunities with regard to primary healthcare units being electrified across Africa. We're seeing that narrative coming out of COP27. And it does feel, we know there is another pandemic coming. And what we have lost in trillions on economic growth, the kind of investment in these areas, investment in community health workers and the health system strengthening that then raises all boats in relation to being able to respond to your malarias, on your HIVs and TB, as well as the infrastructure in place to counteract the next pandemic. Absolutely vital.
Does it concern you that we're looking at a global recession now, and what that might mean for the willingness and ability to spend now, because there's the temptation to say, well, we just got out of a pandemic, and we've got other things to worry about. We've got food security issues, we've got an energy crisis, we've got a cost of living crisis. We need to focus on other things. Do you think that there's a risk that there might be a bit of backsliding here, a little bit of complacency around the need to keep up the investment?
There could be a risk, but you like to think about how the NHS is portrayed in this country. There's no politician going to stand up and say they don't want to invest more in the NHS. We know that the Cabinet Office had a pandemic at the top right of the risk matrix for a very long time, and we've seen it happen. So I do think that the structures that are in place now, for instance, some of the learnings we've taken in terms of how to respond to Ebola, there are now structures, Médecins Sans Frontières, a rapid response organization to respond in that way. I think taking some of those lessons into the global response from the private sector, foundations, governments, NGOs as well, we now know what good looks like, and let's put that mechanism in place to respond to the next one.
I think we're also you're still in a situation where in the healthcare systems, where there's essentially a backlog as a result of COVID. Yeah. And so, in certain parts of the world, you're seeing, people going into hospital for a procedure, might have been in hospital for 3 days with that procedure. Now it's over 10 days. Why is it over 10 days? It's because there was a long period of time when they were not treated. So they're going in now, they're sicker, more things go wrong with them. And so what that is triggering is how can we get these people out of the hospital safer and faster and open up the beds? And it's creating a huge problem. So you don't have to wait, if you like, for another pandemic to come along to figure out that it makes a lot of sense to be able to monitor patients continually and remotely, either before they ever get sick, so you can basically do something early, or when they are sick, to check that they're not getting sicker and that they're heading in the right direction. So these technologies naturally need to be, this type of diagnostic and monitoring technology needs to be deployed now out of financial urgency in many healthcare systems. So where we're sitting, there is a crying out for that. There isn't we're not waiting for something else to happen. It's actually, the pressure's there.
It's a good point. If you had to put a timeline on when you would see this becoming a mainstream phenomenon, is that something that you can do at this point, or is it too difficult to tell?
I think it's already happened there, because we do have wearable devices out in the market. You've got Fitbits and Garmins and Apple Watches and so on, and they're measuring some of the key biomarkers that you need to measure, and you get some useful information. And more medical systems and medical professionals are keen to know the information from those devices from their patients. So it's kind of already there. The infrastructure is there. These devices communicate with the cloud. They store the data. They report the data on your mobile phone. It's so on and so on. You can give access to your physician. So all of that is there. It's really the next stage is to just make those type of devices much, much more powerful. Yeah. And we've developed this type of device as a professional device for the healthcare system. We're looking for regulatory approval, et cetera, et cetera. But over time, the functions in here will most probably become standard functions in all wearables anyway.
Would you say that regulation is perhaps the biggest obstacle?
I don't think it's a big obstacle in the parts of the world where the healthcare system has the money to afford to do this, and the business model for them is justified, because if the saving is immense if you can safely send somebody home a day earlier, and then you've paid for it basically. So I don't think there's any issue there. In terms of the biomarkers that we have here, in terms of things like FDA approval, this is what they call a 510K class 2 type of approval, because you're looking at functions that already exist. It's just we put them all together in one place. The regulatory situation I'm thinking more of is in countries where the flexibility in terms of the moving the data around, possibly not having the right data infrastructure to process the data locally, those regulatory issues could hold back the deployment.
Right, so it's less opposition, more about just having the capacity effectively to do it properly. Fergus?
I was just going to say, I think there's three interesting points going on here. So you've got this, which is definitely the future. We've then seen the COVID-19 response where governments were able eventually to get out of their own way. But whether health information systems are actually working on a day-to-day process, I'm not sure. So for instance, there's still a lot of PPE that has been over-ordered that is gently going off in warehouses around the world. And we've just been able to get millions of pieces of PPE to Tanzania on behalf of the Irish government, who were concerned that it was not able to be used. And actually, just as it arrived, there was talk of an Ebola outbreak over the border in Uganda, and then that PPE was able to be used in real time. So it feels like we can do it, but that's the structure of sharing information at a macro level about the early warning systems, but as also the capability that already exists. We should be doing more of that.
Yeah, I think one point associated with that is the analogy that one uses. How does your app on your phone tell you that there's a traffic jam on the freeway? It's because all the phones with, let's say, Google Maps are stationary in a particular location. So that is anonymized data that comes back. Now, today, that's about your location, but it's anonymized. But in principle, there is you've given up that information to say where you are, which is to the sort of, if you like, the good of your fellow men and women in that traffic jam. or we want to avoid the traffic jam. But when you talk about medical information and aggregating that medical information, that equally is, to some extent, is comparable in terms of the privacy associated with your location. But being able to do that gives you the heat map. If enough people have got these devices on, gives you the heat map. And so you can say, okay, here is an evolving problem. I can actually see it real time evolving, and meaning that I can react, days, maybe weeks before I otherwise would be able to react.
Yeah.
But that does require, people to be comfortable with sharing the information.
I'd echo what Fergus said. It seems kind of obvious that this is the future in some fashion. And if I had any money, I'd be looking to invest. If you do have some money, you might want to think about investing now, because it's very intuitive. Right? You can just kind of see it. It kind of makes sense. Fergus, did you want to come back on anything?
No.
Okay, then I'll switch to just one more thing to touch on. Vaccines. We know the story. The majority of vaccines were developed, produced in so-called developed economies, much to the detriment in the end of a lot of emerging markets. Are steps being taken? Do we need to take steps to change that picture? So next time around, the production of it is, well, one, more efficient, two, much, and of course, much more importantly, more equitable, and that the production and distribution isn't this lopsided affair.
Yes, so it is happening, but I think it's going too slow for comfort at the moment. So everyone involved in the COVAX response, it was very difficult when the Serum Institute had to stop producing and had to focus internally, understandably, on their own population needs in India. And that really stopped the massive rollout that was happening. I love that Barack Obama quote that says, before you start doing interesting new things, stop doing stupid stuff. So, the three stupid stuffs are: let's prevent export bans on life-saving vaccines and other treatments. Let's facilitate the sharing of intellectual property, that's absolutely vital, and don't disband those COVID-19 task forces. They've been really useful, but let's mainstream them into that health system strengthening narrative we've been talking about. Then you can get into better co-funding of vaccine manufacturing sites, particularly across Africa, improving regional cold chain infrastructure, and investing in the World Health Organization and some of these rapid deployment funds they have.
Yeah. So you might wonder what this technology has to play in terms of the development of vaccines. It's further down the line, you would think, but no. I mean, in the development of vaccines, you've obviously got to go through the clinical trials before you start to apply it, and it was done in lightning time. But really, it would be a crime in the future for any kind of drug clinical trial not to have the cohorts in those trials wearing these type of devices, because you will then get a much greater insight and granularity into the data and much more certainty or concern over the safety of a particular vaccine.
Right. One final quick question, and then we will wrap up the discussion. What's your top 3 to-do list for pandemic preparedness for the next time, if you had to pick 3 things? Doesn't have to be 3, could be 1, 2, could be 5.
Indeed. So for me, it's always about the community health workers. That's where the rubber hits the road. That's where you can push back against that anti-vax narrative you were talking about. There needs to be a willing arm at the end of this chain, otherwise there's no point. So that's absolutely vital. Actually, a good supply chain and good procurement is strong value for money and saves lives, and that's absolutely vital as well.
I think overall in the healthcare system, we need to move from what is really a sick care system where we react to people being ill to a real health system where we predict as early as possible that they're getting ill and intervene with all the reduction in cost, a better outcome for the patients, et cetera, et cetera. So from that point of view, obviously this is the type of technology, but from the point of view of taking this technology as it's deployed, it's getting people to agree to be able to have their data aggregated so you can see these heat maps and see where the problems are starting.
From sick care to healthcare. I like it. I think that's a good way of framing it. Ferguson, Andrew, thank you so much for the discussion. And thank you for listening. Please join me in thanking the speakers.
Thank you.
Great.
Thank you very much.
Thank you very much.
Gents.
Thank you.
Pleasure.
Thank you.
Okay, we have one more. And we are going to stay on the theme of healthcare. And, you know, we've had big brain after big brain on the stage today, but this is a true big brain panel. We are talking about health tech and the future of health delivery. And I was checking out some of the bios of the people who are on here, and it's just way over my head. But can I ask the panelists, actually, no, we're going to start with some opening remarks by Frank Hester, who is the CEO and founder of TPP. Is Frank in the room? Not yet. Okay, he's coming. I'm told he's coming. So we're gonna expand the discussion. We're gonna very much now take a forward-looking perspective on this and get an insight into what kind of technology is reshaping and transforming. Sorry. Yeah. Is he? We'll break for 3:30. Okay. Okay. So back at 3:30. Okay, good news, everyone. You've got a break, unscheduled, impromptu. And it's good because I don't have to stand up here and talk for 25 minutes. So we're going to break, 3:30, we'll be back, and we'll be looking at the future of healthcare. You don't want to miss it. It's fascinating stuff. See you in a bit.